Yeah, sorry. Maybe after Libby's presentation, yeah, she actually informed you all the almost changes in the morning. But anyway, I will supplement more. And thank you, Professor Juliana Chen and Professor Philip Lee, to invite me to give the talk. Because the topic is given by the conference, actually I enjoy and think about the topics many times and then try to put in this way and share why we are going to establish the Primary Healthcare Commission. Hospital Authority in Hong Kong is the major healthcare provider, although Department of Health provide some services. Look at the policy in HA, it provides prevention, curative, and rehabilitation. Okay, so remember that prevention is still a major role of hospital authority, although it's managed the hospitals in Hong Kong. So the topic today is DM. So I pick up the clinical guideline, which has been published since 2008. And at that moment, there are two circles. One is primary care and one is secondary care. But today, I look at the guideline again. The primary care, secondary care disappeared. And the general outpatient clinic almost equivalent to specialist outpatient clinic. That means HA upgrade the general outpatient clinics to specialist level. And also in the morning, you hear Dr. Leung present that the family medicine also go for a lot of specialized drugs, and that they think the more drugs they get, they can have a better patient care. So remind this, so it seems to me it's moved away from primary care. And then look at the only clinical practice guideline that has been published in the Hospital Authority on diabetic control. There are many blue zones because that are the resources they are going to put in. And there are 4 gray zones, and I circled the one, the prevention. Sorry, the prevention is out of the scope of this guideline. Okay. Look at the guideline. They did have some life course modification, the intervention. But sorry, it's subject to resources availability. So you look at this moment, what's the picture in Hong Kong is, Hong Kong, we put up all the things under specialist care, and the patient, they will go for treatment only when they see doctors. So they queue up, sorry for the Chinese only, that the one is on your right side is hospital with medication and surgery. Okay, so they're long queue. And for the right, your left side is the lifestyle modification with prevention. Sorry, it's 0 patient waiting there. So what's the picture to me and also to the government is that now we upgrade everything to the hospitals and manage under hospital care. So that's why even, sorry, Dr. Chau is my friend, but I enjoy his talk so much. But I hope the next time, the one who advocate for literacy is not the chief of service or specialist hospital in Hong Kong. I hope everyone who can come out and say, yes, let's improve the health literacy. So the issue in Hong Kong is that we invest, okay, we invest 80 or something percentage of our money into the secondary and tertiary care. And we only invest 17% of public money in the primary health care. And so sorry that with the upgrade of GOPD to specialist care, so you can look at the very, very tiny circle, there's a bit on the public-private interface. So that means we all like the, go to specialist level. But in the COVID, if in Hong Kong, we have a very bad experience is in the 5th wave, if hospital is used to cater everyone who got infected of COVID, then we result in thousands of elderly waiting outside E&E, and some of them basically cannot have any water and food, which is very basic to a patient who has been admitted in hospital. So do we think that it will happen in the DM and hypertension? I think yes. If all the diabetes and hypertension goes to hospital and managed under hospital, what's the picture that will be? So this is the worry of the government, because in the coming 10 years, we have 1 million more of patients who got chronic disease. 60% of them are hypertension and DM. So you can imagine today already the general outpatient clinic has 5 million people attendances, 5 million attendances a year. If all those patients go to GOPD again, I cannot imagine what's the picture that will be. So that's why we want to think about it. And also, this is the only data I can get from HA, from Eva's team, that we start to look at if the patient go into a hospital authority, start with hypertension, what's about their problems after 10 years? Sorry, I think more than 50% of them have other chronic disease developed during that time, during this 10 years. So whether we can do something other than those specialist care and go to more community and primary care so we can have efficient use of resources. RAM program is really excellent program. You have, shared the result from RAM, which show very significant improvement. But this is nowadays, I think, is the thing is whether it's go to the plateau, whether we can do further the RAM in the hospital authority. I know that the waiting time is 3 years now for RAM. So if more people go to hospital authority and the general outpatient clinic, what will be the waiting time? If the annual assessment becomes 6 years assessment, whether we still can achieve the outcome that we can see. So that's why when the government look at the problems, could we do something at the private? Because one of the presenters showed that 80% of the primary care attendances actually happen in the private. And also 60% of them basically is the doctor's consultation. So now look at the, this is one of National Diabetic Prevention Program in the United States. So you can see that they are looking at the prediabetes. And 1 in 3 of the adults who have diabetes, and 8 out of 10 don't know they have the prediabetes. And if you can look at some study that the they can start some treatment like placebo, metformin, and modify the lifestyle, you can see that after 10 years, the people who had diabetics actually is much, much lower. So for the prediabetes group. So do you think that the metformin and lifestyle modification, simply two very simple things, can prevent a lot of the diabetic patient in the future? I think this could be what we are thinking of. Hong Kong, I just mentioned, we are going to have 1 more million people who have chronic disease. And this is the update figure we are going to promulgate. Basically, we have 50% of our population more than age of 45 who have hypertension, DM, pre-DM. And 30% of them actually known to have DM and hypertension. So this is based on the new population health survey in the 2020. So I would like to share that not only that all the DM patients now, 80% have managed in the under HA, but we still need to bear in mind that there are still 20% of population age more than 45 who have some sort of hypertension and prediabetes. Sorry, here the prediabetes, we cut line at hemoglobin A1C at 6.0. That means we have 15 more % people who have hemoglobin A1C more than 5.7. So I put them in the yellow part, and then you can see that I didn't put the normal under the 47.1% because I don't know how to express that. But at least the government don't want to show the public that when you're over age 45, 70% of you have some problem. So okay, we try to cut it to 50%. But please remember that when you go up to 45 years of age, 50% of you have some issues. So now we try to start some program for DM hypertension. We thanks Dr. Martin and their groups. They agreed that we start to screening all the people age over 45 without known and hypertension and DM. So we aim at the 20% of whole population more than age 45 to have some sort of access to a public subsidized things to screen for DM and hypertension. So the program is a bit complicated. We call CDCC. because this is part of the reform, because we think that if we try to use the GOPD PPP that HA has offered, we may encounter a lot of difficulties, because in their theory is they try to relieve the pressure of HA. But we try to think whether we can refocus the prevention in the community first, so groom up the culture, and then we look after the HA in the second phase or third phase. So in this program, we try to develop a package for family doctors. We want to recognize the doctors outside, although 50% of them still don't know 70% hemoglobin A1c should be the target they are trying to achieve. But we start to need to know some of them who really are good and can join the family doctors. So we offer a package. This package is not 100% pay package. Up to $400, $430 per consultation to those who have DM and hypertension or pre-DM. But we hope that they achieve a certain target so they can get this amount. If they only want to get the some money to treat some patient without target in their mind, sorry, they have a very low subsidies. That's the pay for performance we try to incorporate. And so this is what we hope to learn from the other financing model. Another thing is we try to develop community drug formulary. That means we try to lower down the drug cost of the private. We try to set up a list, and then we go through a central bulk purchase of the drugs, and hope that to provide some basic support to the family doctors who can have a profitable, support to the program. So that is the few things we try to do. So yesterday we went to Legislative Council, and we told the members that the future community drug formulary, 90% of them, the drugs in the list will be less than $1, and 60% will be less than 30 cents. And another figure I cannot show, but the very significant proportion of drugs will be under 10 cents. Okay, so that will be the things that we try to look for. And then second thing, I'll go quickly because the time is up. I will try to show that the program is not only for the family doctors, they need the allied health support, need the nursing support, which we need to learn what's the other country can share. So I'm so happy that I can share Indian's model, I can share UK model in the morning. And then we'll go for IT system for sharing of the information, because the private sectors are so scattered and no communication channel at all. And also we try to provide incentive to patient. That means if the patient, they can fulfill their targets achieved, they can have more voucher in next year. So we hope to incentivize the people can go for the target, but the problem we face is how can we tell the patient what they need to do and how they can ask family doctors what they should got. So this, the problem goes to, in the morning we discussed with Professor Joseph Loy, not Professor Loy, Professor Loy Siu-Fei, and see whether we can do more on the patient communication. That's our problems. And then in the future, we develop bi-directional referral like Indian's model, but this time we just look after upload model first, because download model is too complicated, and then see whether the HA can provide one-off consultation to those family doctors and support them. So this is roughly the things we try to go for. A lot of providers, and hope to make the CDC see a more comprehensive program. So I don't talk about them too details. One thing is for phase one, we start with district health centers. We hope to empower them. So I think to have any tools I can buy or adopt, and I try to see whether we can purchase those services with quality control. And then in phase two, we start the recruitment at family doctors clinic. So any clinic they join the program, they can recruit the patient, make sure that the patient of those age 45 can join the district health center as well, because the program can only allow the two things happen in the same time. And the patient can only get the subsidies from the doctors assigned to them. That's the family doctors. So we start with hypertension, pre-DM, and DM. And family doctors, yes, as you show, Dr. Martin showed a lot of things that family doctors may not ready in the community. So that's why we need to assign the responsibility. I hope that they accept this responsibility and understand what's the minimum need to do for the patient under them. And then we also educate the patient when you see doctors, what you should ask them to do for you, okay? Because there are a lot of things that family doctors can earn from them, but they hope to provide them minimum things they need to do when they seek the medical service from the family doctors. So patient empowerment, I really learned a lot today. Health literacy, patient communication. Thanks very much for many speakers give me a lot of good insight, and we should try to look for that in the future. I don't talk about bidirectional referral because it's quite complicated, and we need to come up with a standardized criteria so that when the referral happen, it won't cause too much pressure to HA, but at the same time, HA learn how to manage the patient at once and then communicate with the family doctors and treat the patient in co-care approach. So e-health is another thing I won't talk, but this is so many things come in. That's why we plan to establish a primary healthcare system with an aim to build a long-term doctor-patient relationship. We hope we have community support like nursing, allied health support to come in to support the family doctors. We need to have a very affordable package in terms of investigation and community drug formulary. We hope to have some quality insurance system in place. And also we developed the direction referral system with HA and hope that will become part of HA in future. And this is the reason we need to establish a primary healthcare commission and to try to change the treatment-centric system to prevention-focused system and hope to have a more policy framework incorporate in the future development. So thank you so much for your attention and patience, and thank you. This is